Hi guys, so this video is meant as a guide to basic concepts in the ICU. It's broken up into 4 sections. First is basic concepts and equipment in the ICU, including endotracheal tubes, tracheostomy tubes, ABG versus VBG, etc. The next section is mechanical ventilation and rounding on mechanically ventilated patients, including topics like ventilator settings, sedation, paralytics, and extubation readiness. And the 4th section is miscellaneous high-yield topics in the ICU, where we'll cover CRRT, admission criteria to the ICU, and mnemonic for rounding on your patients. At the bottom of the video are timestamps to individual topics, so if there's one topic that you wanted to look up, you can click on that topic. Additionally, there are timestamps to the summary of each topic, so if you're short on time, you can just click through to the summary timestamp. All right, let's start with our first section, which is basic concepts and equipment in the ICU. Okay, so to start the mechanical ventilation section, let's start with the components of the endotracheal tube. So what's this part here? Yeah, so this is the endotracheal cuff, which is an inflatable balloon at the distal end of the endotracheal tube, and it sits here in the trachea. And what is the purpose of the endotracheal cuff? So when inflated, the endotracheal cuff creates a seal in the trachea, which allows for positive pressure ventilation and additionally protects the airway from aspiration. So when the ET tube is in place, the epiglottis can't close. So the airway is at high risk of aspiration of oral secretions and gastric content. So having the cuff properly inflated decreases the risk of aspiration and developing ventilator-associated pneumonia. And then what are these two lines here? Yeah, so this blue one is the inflation line, which can be used to inflate the endotracheal cuff. It can also be attached to a pressure gauge or a manometer to ensure that the cuff is adequately inflated. And what is this? Yeah, this is the subglottic drain. And what's the purpose of the subglottic drain? So the subglottic drain runs along the endotracheal tube, not in the lumen, and at the distal end, immediately above the cuff, is a small opening. So the subglottic drain can be attached to a vacuum seal to allow for secretions to be suctioned off, and this prevents secretions and gastric content from accumulating above the endotracheal cuff. And what are the numbers on the side of the endotracheal tube for? So the numbers are a measurement in centimeters from the tip of the endotracheal tube. And once the endotracheal tube is in place, the numbers are used as a measurement from the tip of the ET tube to the teeth. And why is this useful? Well, if the tube is placed too deep, there's a risk of the distal end of the tube sitting in one of the main stem bronchi. And if the tube is not placed deep enough, there's a risk of the tube becoming dislodged. So the numbers are a rough estimate of how deep the endotracheal tube has been placed. And how do you know how deep the endotracheal tube should be placed? So the depth of the ET tube is based on the height and gender of the patient. So if you type into MD-Calc ETT, you can calculate how deeply the ET tube should be inserted based on gender and height. And how long can you leave an endotracheal tube in place? So an endotracheal tube can be left in place for approximately 2 weeks. And what are the risks of leaving an endotracheal tube in place for longer? So the issue is that the endotracheal tube is very irritating to the surrounding laryngeal tissue, vocal cords, and epiglottis. And leaving the tube in place for a prolonged period of time can lead to the formation of granulomatous tissue, ulceration, vocal cord paralysis, irreversible tracheal stenosis, and importantly, laryngeal edema. And in particular, laryngeal edema can be fatal, since when you go to remove the endotracheal tube, all of the surrounding laryngeal edema and swelling can cause the airway to close off, which we'll discuss later. So for all these reasons, when the endotracheal tube has been left in place for close to 2 weeks, and ideally after 1 week, it's important to discuss next steps, such as placement of a tracheostomy tube. So let's talk a little bit about the tracheostomy tube. There's 3 parts to it. So what is this here? Yeah, so this is the same thing. This is a tracheostomy cuff. So it's the exact same thing as the endotracheal cuff. This here is the inner cannula, and this is the outer cannula. So this inner cannula goes inside of the outer cannula, and it can be easily taken out and cleaned and exchanged. And then what is this? Yeah, so this is the obturator. This is a hard piece of plastic. Both of these are kind of flimsy pieces of plastic that sit in the airway. But the obturator is a hard piece of plastic, and it's almost kind of like a stylet. It can be used to push the whole thing back in. So for example, if a tracheostomy tube were to fall out, you want this at the bedside so that you can place the whole tracheostomy tube back in quickly. Okay, so let's talk briefly about dislodgement of a tracheostomy tube. So a dislodged tracheostomy tube can potentially be an airway emergency. This really depends on how recently the tracheostomy tube was placed. So if the tube was placed greater than 7 days ago, the tracheostomy tube can usually be replaced at the bedside using the obturator. And this is because it takes about 7 days for that tracheostomy tract to mature and heal. And when the tract is matured, that tract guides the tracheostomy tube back into place, and there's a high rate of success when attempting to replace the tracheostomy tube at bedside. So in the case of a dislodged tracheostomy tube that was placed greater than 7 days ago, the first step is to attempt to replace the tracheostomy tube at the bedside. If the tracheostomy tube was placed less than 7 days ago, and especially within 72 hours, it's very difficult to replace the tracheostomy tube at bedside. And this is because there has been insufficient time for the tract to heal, and all the tissue planes around the tract are very collapsible. So this is considered to be an airway emergency, and the first step is to secure the airway, intubate the patient with the endotracheal cuff inflated below the stoma, and then once the patient is securely intubated, then an attempt can be made at replacing the tracheostomy tube. So when you're on your ICU rotation, you'll frequently hear the respiratory therapists or the ICU nurses refer to a patient being on a trach mask or a trach collar. And this is a mask that is placed over the tracheostomy tube. And the purpose of a trach mask or trach collar is to provide humidified air, which is blown over the tracheostomy. So we rely on the oropharynx to humidify the air that we breathe, and a patient with a tracheostomy bypasses the oropharynx. So the purpose of the trach collar or trach mask is to humidify the airway. So a patient that's on a trach mask or trach collar is not attached to a mechanical ventilator. So if you hear the nurses refer to a patient being on a trach mask, that means that they're breathing spontaneously on their own, and the mask is just there for humidification of the airway or for supplemental oxygen. Okay, so let's talk a little bit about the tracheostomy cuff and when it should be inflated or when it should be deflated. So if a patient with a tracheostomy tube is connected to a mechanical ventilator, do you think this tracheostomy cuff should be inflated or deflated? Yeah, it should be inflated so that the air comes in and out through the tube and doesn't go back up the trachea. What if somebody with a tracheostomy tube is not hooked up to the mechanical ventilator? Do you think this balloon should be inflated or deflated? So in a patient who is not hooked up to a mechanical ventilation, who's breathing spontaneously, you want this to be deflated, because otherwise that air is just going to be going in and out of this tube if it's inflated. It takes a lot of pressure to push the air through such a small airway. Imagine breathing through a straw. So in someone who is not attached to the ventilator, you want this to be deflated. What if a patient with a tracheostomy tube wants to speak? Should this balloon be inflated or deflated? Yeah, it should be deflated so that the air goes up and engages the vocal cords. So imagine that you're rounding on a patient with a tracheostomy tube, and you go to talk to them, and they're trying to talk, but they can't quite make sound. What do you think the issue is? Well, the problem is that when they're going to talk, the air is going up and it's engaging the vocal cords, but it's also getting blown out here. There's just not enough airflow coming up the trachea and engaging the vocal cords to cause them to vibrate and create sound. So you need something to keep the air from going out of the tracheostomy tube and just going up and engaging the vocal cords. And that's this here. And this is called a passy-Muir valve. And you'll hear people talk about it all the time on the ICU. And it's a one-way valve that attaches to the end of the tracheostomy tube. And it allows air to come in when you breathe in. But when you go to talk, it doesn't allow the air to go back out through the tracheostomy tube. So that all the air is forced to go up and engage the vocal cords. So when the passy-Muir valve is in place, it's very important that the tracheostomy cuff be deflated, because the passy-Muir valve is a one-way valve that does not let air out through the tracheostomy tube. And if the cuff is inflated, there's no way for air to escape. It can't go up the trachea, out the mouth, and it can't go out of the tracheostomy tube. So anytime the passy-Muir valve is on, the tracheostomy balloon has to be deflated. So we've talked quite a bit about the endotracheal cuff and the tracheostomy cuff. This is a pressure gauge, and it can be attached to the inflation line. It measures the pressure in the cuff. And you want the pressure in the cuff to be high enough that it creates a good seal in the trachea that doesn't allow air or secretions to go around. But at the same time, you don't want the pressure to be too high, because if the pressure is too high for a sustained period of time, you can have ischemic damage to the trachea. So ideally, the pressure is between 20 and 25 millimeters of mercury. If you're having difficulty getting a good seal on the endotracheal cuff, there's two things you need to consider. One is that there's potentially a hole in the endotracheal cuff, and you can measure that with the pressure gauge. You can see if the cuff is able to maintain pressure. The other possibility is that the endotracheal tube is actually migrated, that the cuff is no longer sitting down here in the trachea, but is actually in the subglottic space. And in that case, that patient is at very high risk for extubation. So you would want to get a chest x-ray to verify that the endotracheal tube is still in place. So earlier we talked about the subglottic drain, which is this yellow line here, and this is just a diagram of it, suctioning off secretions that gather above the endotracheal cuff and suctioning them off into the vacuum bottle. And we mentioned that the subglottic drain is one intervention that we can use to decrease the risk of developing ventilator-associated pneumonia. So there are 3 other interventions that have been shown to decrease the rate of ventilator-associated pneumonia in the ICU. So what are those 3 other interventions? So one is elevating the head of the bed. Another is minimizing sedation, which we'll talk about later. And a third is ensuring adequate inflation of this endotracheal cuff. And in doing so, we decrease the risk of aspirations and secretions getting into the lungs. So we talked a little bit earlier about using chest x-ray to confirm appropriate placement of a endotracheal tube. And so what are we actually looking for on the chest x-ray to make sure that the endotracheal tube is in the correct place? So the main thing we look for is we measure the distance from the carina to the endotracheal tube. And that distance should be between 3 and 5 centimeters. And so you can actually measure it on a chest x-ray, you can measure that distance. So the carina is here, here's the endotracheal tube. Sometimes it can be difficult to visualize the carina, and so another trick that you can use is use the vertebrae. So the endotracheal tube should be sitting between T2 and T4. So where the first rib comes off, that's T1, T2, and here's T3 and T4. So you want the endotracheal tube to be between T2 and T4. Another big thing you want to look at is make sure that both lungs are inflated. Because if only one lung is inflated, you should be concerned that the endotracheal tube is sitting in one of the main stem bronchi. All right, so let's talk a little bit about ABGs versus VBGs. What information do you get from a blood gas, in either an arterial or a venous gas? Yeah, so you get the pH, the CO2, and the O2 content of the blood. And as a side note, anytime that you're reporting a gas, a ABG or a VBG, you always present it in the same way. So first you say the pH, followed by the CO2, followed by the oxygen. And when you say the oxygen, you always report what type of ventilation they're on. So for example, you might report an ABG as 7.4, 35, 80 on a rate of 15, tidal volume of 500, PEEP of 5, FiO2 of 60%. Or if it was on a high flow, you might say 7.4, 35, 80 on high flow nasal cannula at 40 liters at 60%. And the reason that the CO2 has to come after the pH is that it allows the listener to quickly determine if the pH is being affected by either a respiratory acidosis or a respiratory alkalosis. So you always say the CO2 after the pH. So let's talk a little bit about an ABG first. So assuming that the ABG was drawn correctly and there was no mixing with venous blood, which of those 3 values are reliable on an ABG? An ABG gives you a reliable pH, it gives you a reliable CO2, and it gives you a reliable blood oxygen level. All 3 of these values can be trusted on an ABG. If you need an accurate snapshot of a patient's respiratory status, an ABG is a very useful tool. So what are the disadvantages of an ABG? Well, if a patient has an arterial line already in place, there's really no disadvantage to an ABG. It's accurate, it can easily be drawn off the A line, off the arterial line, so there really is no disadvantage to an ABG in that case. However, if a patient does not have an arterial line in place, then you have to get an arterial blood draw. And getting arterial access is very painful for the patient. And additionally, there's a risk for hematoma formation, for bleeding, and sometimes nerve damage can be associated with getting arterial access as well. So the advantage is an ABG is very accurate, gives you very accurate information. The disadvantage is that there is risk associated with getting an arterial blood draw. What about a VBG? Well, the advantage of a VBG is that you don't need arterial access. It can be drawn off a peripheral line. There's very low risk of hematoma, there's low risk of bleeding, there's low risk of nerve damage. It's also much less painful for the patient. The pH on a VBG is also very reliable, and you can use it interchangeably with an ABG. The disadvantage of a VBG is that the CO2 and the oxygen levels are much more variable on a VBG than an ABG. And in particular, the venous blood oxygen level is highly variable. And this is because the venous concentration of oxygen and CO2 depends on multiple variables such as cardiac output and metabolic demand. In terms of cardiac output, take for example a patient with cardiogenic shock. Their venous oxygen content will be low, even if their arterial oxygen content was normal. Whereas a septic patient will likely have a high venous blood oxygen content. In terms of metabolic demand, take for example a patient that just got up out of their bed, they walked over to the bathroom, and you were to draw a VBG right after they got back into the bed. Well, the metabolic demand for their muscles will result in a higher level of CO2 and a lower level of oxygen on the VBG. So a VBG has more variation on the CO2 and oxygen content. However, where a VBG can be really useful is in trending blood gases in a patient who does not have an arterial line, and it also gives you a rough estimate of their CO2. So, for example, a patient comes in with a COPD flare. A VBG can give you an accurate pH, and it can also give you a rough estimate of their CO2. And in many cases, that may be all you need. And then on serial VBGs for that patient, you can measure their response to BiPAP. And so you can see their trend. As long as their CO2 is going down with the BiPAP, that may be enough information without having to submit them to the pain and the risk of drawing serial ABGs. So in summary, the pH is very reliable on both an ABG and a VBG. The CO2 on a VBG is less reliable, but it's still good for giving you a rough estimate. You can tell if it's really high or if it's really low, and it's also good for trending CO2 levels. With regards to oxygen, if you need a very accurate measurement of a patient's blood oxygen, an ABG is better than a VBG, but a VBG can give you a rough estimate of oxygenation. There's a conversion from venous gas to an arterial gas. By adding 0.05 of the pH on a venous gas, you can get an estimate of the arterial pH. And to get a rough estimate of the CO2 on a venous gas, you would subtract 8 to get an arterial CO2. So what arterial oxygen content would you consider as hypoxemia on an ABG? Yeah, so less than 60. So less than 60 on an ABG is considered hypoxemia. And what would you consider as hypoxemia on a pulse oximeter? Yeah, less than 90. And so a value of 60 on an ABG corresponds with a value of 90% on a pulse oximeter. All right, so let's talk a little bit about mechanical ventilation and ventilator settings. So what are the controlled variables on a ventilator? So the first one is the rate. You can control the number of breaths per minute. If the ventilator is set to volume control mode, then you can control the volume. You control the PEEP, and then you control the FiO2. And you can see here on the measured variables, you can see the volume. This is at the peak of inspiration and expiration. And you can see the flow, so air is flowing into the lungs and flowing out of the lungs. And you can see the pressure. So this is the pressure at the peak of inspiration, and there's a plateau here, and then during expiration. So why does the pressure never reach 0? That's because of the PEEP. So in this case, there's a PEEP of 5. So positive expiratory pressure. So at the end of expiration, there's still a pressure of 5. Okay, so I want you to imagine that your team is about to intubate a patient. So how are you going to choose what vent settings to put this patient on? So how are you going to choose the respiratory rate? So the respiratory rate you're going to choose is based on the respiratory rate of the patient prior to intubation. So imagine that patient is breathing at 20 breaths per minute. You want to match the respiratory rate to 20 breaths per minute. The exception is if it's greater than 30 breaths per minute, then you wouldn't set it greater than 30. But generally, you want to match the respiratory rate to the rate prior to intubation. What about the volume? How are you going to choose a volume? So would you base it off of weight? Well, do you think someone who's 5'5" and weighs 200 pounds has different size lungs than someone who's 5'5" and weighs 100 pounds? No, so they have the same size lungs. And so we use something called ideal body weight. So type in ETT or ideal body weight into MDCalc, and you can actually calculate based on gender and height the ideal body weight of a patient. So once we know the ideal body weight, then we use 8 cc's per kilogram in most patients, approximates a normal physiologic tidal volume for a patient. So 8 cc's per kilogram in most patients. If a patient has ARDS, acute respiratory distress syndrome, then we choose a lower volume. So we would use 6 cc's per kilogram. So in most patients, 8 cc's per kilogram of ideal body weight. In patients with ARDS, we use 6 cc's per kilogram of ideal body weight. And we'll discuss more about ARDS later. And then how are you going to choose a PEEP? So in general, you're going to start at a PEEP of 5. There are some exceptions to this, but in general, you start at 5, and then you titrate the PEEP from there. And then what about the FiO2? So generally, we start at FiO2 of 100%, and we down titrate based off the pulse oximeter and off of an ABG. So once the patient is intubated, there are really 3 pages you'll get. Problems with CO2, problems with oxygen, and the problems with high peak pressures. So let's walk through and troubleshoot each of these 3 issues. So let's imagine that the patient that your team has just intubated gets an ABG 30 minutes later, and it comes back and it says pH is 7.3, CO2 of 50, the O2 is 75, on a rate of 15, tidal volume of 500, PEEP of 5, and an FiO2 of 60%. So what stands out on that ABG? Yeah, the CO2 is high. It's 50. It should be between 35 and 45. So which two variables on the vent control carbon dioxide? So as you probably recall, CO2 clearance is determined by minute ventilation, which is a measurement of the amount of air that enters your lungs per minute. And minute ventilation is a function of breaths per minute, or the respiratory rate, times the tidal volume. Since we control both of those on the ventilator, you can adjust either the respiratory rate or the tidal volume to control the clearance of carbon dioxide. In reality, we change the respiratory rate. And why don't we change the volume? Well, changing the volume affects other parameters, like peak pressure. So it's easier to adjust the respiratory rate. So how are you going to change the respiratory rate to bring down the CO2 in this case? So we know that we need to increase the respiratory rate to bring the CO2 down. So how are you going to choose the new respiratory rate? You're just going to pick a random number? So that's where this formula comes in, and this is very helpful because you will get this page in the middle of the night. The CO2 is high, and you need to choose a new respiratory rate. So you can take the current respiratory rate times the current CO2 equals the desired CO2, then you can solve for the new respiratory rate. So in this case, we said the current respiratory rate is 15, the current CO2 is 50, the desired CO2, we're going to choose something between 35 and 45, so 40, and then we're going to solve for the respiratory rate. So in this case, the respiratory rate would be 19. So we're going to change to a respiratory rate of 19. So for problems with CO2, we adjust the respiratory rate using that formula. Let's now move on to talking about the pages you'll get regarding problems with oxygenation. Okay, so imagine the same patient. You get another ABG back in an hour, and it comes back with a PaO2 of 50. We remember that a PaO2 below 60 is considered hypoxemia. So we need to improve oxygenation for this patient. So what are the two variables that affect oxygenation? So we need to improve oxygenation for this patient. So what are the two variables that affect oxygenation? So one is PEEP, and the other is FiO2. And how does PEEP improve oxygenation? Well, it does two things. One, it recruits otherwise closed alveoli, and others, it increases reserve in patients' lungs between breaths to improve oxygen exchange. So this is essentially improving the functional residual capacity. So you can use PEEP or FiO2, and how are you going to choose which one to use? So this is known as the PEEP ladder. It's basically a titration guide to tell you whether or not you should change the FiO2 or the PEEP. So going back to our patient, we want to improve their oxygenation. And let's say, for example, that this patient's currently at a PEEP of 10 and a FiO2 of 60. So following this scale, we know that the next step on the ladder would be to come up to an FiO2 of 70%. So we'd make a change from 60 to 70%. And if again, they were still hypoxemic, we would then make a change from a PEEP of 10 to 12, and we just continue to follow this ladder both to improve oxygenation or when we're trying to wean the vent. We come down based on this ladder. So this PEEP ladder is based off a strategy outlined by the ARDS network, which we'll briefly touch on later. But there's two things I want to call your attention to. The first thing is, earlier we spoke about choosing an FiO2 for a patient that was just intubated. We said that you started an FiO2 of 100% and then down titrate. Well, how do you down titrate based on the scale? Do you choose the FiO2 or the PEEP or both? So the standard protocol is after starting the patient on a FiO2 of 100% and a PEEP of 5 after intubation, you rapidly down titrate the FiO2 to 40% and watch the SpO2 on the pulse oximeter. If the SpO2 falls, then you can use this ladder to up titrate both the PEEP and the FiO2 until you reach an optimal combination of PEEP and FiO2 to meet an SpO2 of greater than 88%. So intubated at FiO2 of 100% and PEEP of 5, down titrate the FiO2 to 40%, and then adjust based on this ladder at the bedside until you meet an SpO2 of greater than 88%. The second thing I want to call your attention to is that you may have noticed on this table there's a low PEEP, high FiO2, and there's a high PEEP, low FiO2. Historically, the high PEEP scale was used in patients with ARDS. However, subsequent studies have demonstrated worse outcomes when using very high PEEPs. So the current guidelines recommend that for all patients, use the low PEEP, high FiO2 scale, regardless of if the patient has ARDS or not. So for now, use the low PEEP and high FiO2 in the ICU. So for problems with oxygenation, we adjust the PEEP or the FiO2, and to decide which one to change, we follow the PEEP ladder. Okay, so we've discussed problems with CO2, we've discussed problems with oxygenation. Now let's move on to problems with high pressures. So these are pages you'll get about high peak pressures. So let's imagine that you get a page telling you that the peak pressure alarm is going off. So this pressure here is greater than 40. And if you look on here, the pressure is getting over the cutoff of 40. So how do you troubleshoot this? Well, pressure is a function of flow and resistance. So since we control flow on the mechanical ventilator, if the pressure is high, we know it must be an issue with resistance. And in a mechanically ventilated patient, what are the two things that contribute to resistance? Airway resistance and the compliance. So the airway resistance includes things like the tubing from the vent, the tube, the trachea, the bronchi, the bronchioles, etc. And the compliance, which is defined as change in volume over change in pressure, is the elasticity of the lungs or the stretchiness of the lungs. A very compliant lung easily expands when pressure is applied. And a lung with low compliance is stiff. It has very little change in volume with an application of pressure. So if the peak pressure alarm is going off, there is a problem with resistance. So what's the differential for increased airway resistance? Mucus plugs, and this is by far the most common, kinks in the tube, the patient biting down on the tube, and bronchospasm. And what's the differential for increased compliance? ARDS, pneumothorax, pulmonary edema, obesity, and air trapping, which we'll also talk about in a minute. So if the peak pressure alarm is going off, how do you know if it's an airway resistance problem or a compliance problem? The answer is that we can use something called an inspiratory hold. So if we look back at our ventilator screen and we look at a pressure curve, well, we can zoom in on this pressure curve. So on this slide here, this is a zoomed in pressure curve. And this is during inspiration. Here's the peak of inspiration, and then during exhalation. At the peak of inspiration, the two things that contribute to peak pressure are airway resistance plus the compliance. But once the air is inside the lung, at the end of inspiration, we can press hold on the ventilator. So we can do an inspiratory hold. And at this point, no air is moving in or out of the lungs. And because of this, we take airway resistance out of the equation. So only compliance becomes a component of the pressure. And this is called the plateau pressure. So when we perform an inspiratory hold, we get a plateau pressure. And we can use this plateau pressure as a surrogate for compliance. So if the plateau pressure is high, as defined as greater than 30, then we know there's a problem with compliance. If the plateau pressure is normal or less than 30, then we know the problem is with airway resistance. Okay, so back to the original question. If you get a page about high peak pressures, the things you want to do are call RT for suctioning in case it's a mucus plug, get a chest x-ray to evaluate for things like pneumothorax, mucus plug, worsening pulmonary edema, worsening ARDS, and then perform an inspiratory hold to evaluate the plateau pressure. If that plateau pressure is high, it's likely an issue with compliance. If the plateau pressure is less than 30, then it's likely a problem with airway resistance. Also, always make sure to go to the bedside. Sometimes you can evaluate the etiology of the high pressures through a physical exam. An RT or the fellow or the attending can help with evaluating for kinks in the tubing or biting on the ET tube. You can use ultrasound to evaluate for pneumothorax and sort out the cause for high peak pressures. The other thing you want to keep in mind is how acute the onset was of these elevated peak pressures. If the onset was very rapid, then you should be thinking of things like mucus plug or pneumothorax, whereas if the onset was slow, then your differential might look more like ARDS or pulmonary edema. So going back to the differential for compliance, we mentioned air trapping. This is actually a very important and dangerous cause of high peak pressure. So let's talk briefly about air trapping. Okay, so what is air trapping? And just for completeness sake, air trapping is also called dynamic hyperinflation or auto PEEP. So air trapping occurs in a mechanically ventilated patient when the patient doesn't have enough time to completely exhale before the next breath is triggered. Because the patient didn't completely exhale before the next breath was triggered, more and more air gets trapped in the lung with each subsequent breath, resulting in increased pressures. So on the flow rate curve, you would see a patient who was exhaling but didn't quite reach zero, the point where air is neither entering nor exiting the airway before the next breath was triggered. And on the pressure curve, what you would see is PEEP that increases after each breath. And what is the risk of air trapping? Well, it increases the peak pressures, and high peak pressures can cause barotrauma to the lungs. But additionally, what can happen is because the peak expiratory pressure continues to increase, you can have increased intrathoracic pressures. And in very severe cases of increased intrathoracic pressure, you can develop obstructive cardiogenic shock. So what are the causes of air trapping or dynamic hyperinflation? The first thing to consider is that the respiratory rate is just set too high. There's not enough time in between breaths to completely exhale. The other possibility is that there's increased expiratory airway resistance. So examples of this would be small airway resistance like COPD or asthma, and these patients are at higher risk for developing air trapping or dynamic hyperinflation or auto PEEP, and large airway resistance, so things like increased secretions. And for all these etiologies, the point is just that for whatever reason, whether it's airway resistance or insufficient time, the patient is not able to completely exhale before the next breath, which causes air to be trapped in the lungs, leading to increasing pressures. So when should you suspect this? So again, when the high peak pressure alarm is going off, air trapping should at least be on the differential. And when you're assessing the patient at bedside for these high peak pressure alarms, you can look at the flow rate. And if the flow rate's not returning to zero before the next breath is triggered, then you should suspect air trapping. The other thing you can look at is the set PEEP versus the measured PEEP. So in this case, we've set a PEEP of 5 and the PEEP is 5. But if the set PEEP is 5 and the measured PEEP is much higher, for example, 10 or 15, then you should consider the possibility of air trapping. And when you look on the pressure curve, what you might see is a breath with a set PEEP of 5, but on the next breath, because of the trapped air and increased volume, you might see a higher PEEP, a PEEP of 10. And on the next breath after that, you might see a higher PEEP of 15. So you see a stepwise increase in the PEEP. So what interventions can we take to counteract air trapping? The first thing you can do is decrease the respiratory rate. So by decreasing the respiratory rate, we give the patient more time in between breaths to completely exhale. The other intervention is to treat any reversible causes of increased expiratory airway resistance, and usually that's secretions. So you can trial suctioning the airways with RT to see if it improves the pressures. And anytime you're evaluating someone for air trapping, check their blood pressure. If the blood pressure is lower, they're having increased pressure requirements. This may indicate that the air trapping is so severe that there's increased intrathoracic pressure and the patient's developing obstructive cardiogenic shock. So in these severe cases, the tubing from the mechanical ventilator is disconnected from the ET tube, and the patient is allowed to completely exhale. And this may even include the application of external pressure with your hand to the patient's chest to assist in complete exhalation. So severe air trapping is not common, but it's something that you should understand and have on your differential when you see high peak pressures. Okay, so we've mentioned ARDS, acute respiratory distress syndrome, several times so far, and you will encounter patients with ARDS. So let's cover ARDS briefly in a few slides. So first off, what's the 10,000-foot view of the pathophysiology of ARDS? So in ARDS, some pro-inflammatory event triggers injury to pulmonary capillary walls, which results in leaky pulmonary capillaries, which in turn leads to exudate of protein-rich fluid, platelets, and even erythrocytes into the alveoli. And the details of the mechanism are complex, but that's the overall concept. There's some triggering event that leads to inflammation, which in turn leads to leaky capillary walls that allows protein-rich fluid to seep into the alveoli. So what are the clinical manifestations of these leaky pulmonary capillaries? The first is hypoxemia. So damage to the pulmonary capillary epithelial cells leads to decreased alveolar capillary permeability, which decreases the efficiency of gas exchange in the alveoli. There's also edema from the leaky capillaries that fills the alveoli and alveolar collapse. Next is poor compliance, and this is due to the leakage of this protein-rich fluid into the lungs that causes them to become stiff. And the third is increased pulmonary vascular resistance. So due to capillary damage, there's increased pulmonary vascular resistance, which increases right heart afterload and eventually leads to something called right heart death spiral. And I find this image helpful. And in reality, it's a reference to right heart death spiral in a massive PE, but the concept is the same. So in ARDS, there's increased pulmonary vascular resistance, which leads to increased right ventricular afterload, which leads to a cascade of events, which ultimately results in RV failure and eventually cardiogenic shock. And in cases of severe COVID, for example, this is frequently the cause of death, right heart failure due to ARDS. So when should you suspect ARDS? Well, we use something called the Berlin criteria, and there's 3 criteria. The first is that you have to have acute onset within 7 days after some trigger or insult, which we'll talk about in a second. You also have to have bilateral lung infiltrates on imaging, and those infiltrates can't be of cardiac origin. In other words, this can't be cardiac pulmonary edema. But how can you know that it's not cardiac pulmonary edema? Well, what you're looking for are the absence of signs of left heart failure as measured by left atrial dilation or increased left atrial pressure on, for example, a TTE or a right heart cath. And if it's a mixed picture of ARDS and left heart failure, a bronchoscopy to sample the fluid in the lung can be obtained to determine if this is ARDS or cardiac pulmonary edema. Because the mechanism of ARDS involves the leakage of protein-rich fluid into the alveoli, if it's ARDS, the fluid sample from the lung will have high protein content, whereas in cardiac pulmonary edema, the pulmonary fluid will have a low or normal protein level. And the third criteria is a P to F ratio of less than 300. And what is a P to F ratio? So a P to F ratio is the PaO2, or the arterial content of oxygen, divided by the FiO2, which is the percent of inspired oxygen. So in a normal, healthy person, an arterial oxygen content might be 80, for example, anything greater than 75. And the FiO2 of room air, the percentage of oxygen in room air, is 21%. So the P to F ratio would be 381, which is well above the cutoff of 300. Whereas in a patient with ARDS, their PaO2 will likely be low, for example, PaO2 of 65, and in a severe case, you might be delivering an FiO2 of 100, and the P to F ratio would be 65. And part of the Berlin definition of ARDS grades ARDS severity based on the P to F ratio. So mild would be 200 to 300, moderate would be 100 to 199, and severe would be less than 100. So we mentioned that part of the Berlin criteria is acute onset, less than 7 days after the insult. So what are some of these insults or triggers that can cause ARDS? So the most common causes are infectious, whether that's sepsis or pneumonia, and the pneumonia can be viral or bacterial or fungal. Other causes are aspiration, inhalation injuries, pancreatitis, or fat embolus, but by far the most common causes are infectious. So what's the management of ARDS? Well, there have been many trials of various interventions in ventilator settings and ventilator modes to optimize patients with ARDS. And of those trials, the only effective intervention to date has been low tidal volume ventilation, which is based on evidence from this trial, which was conducted by the ARDS network in 2000 and established the concept of protective lung ventilation. So in patients with ARDS, using lower tidal volumes of 6 cc's per kilogram rather than the traditional volumes that were used at that time, which were actually 12 cc's per kilogram, resulted in more ventilator-free days and better survival. And the differences between the groups were so significant that the trial was actually stopped early. So in patients with ARDS, we target a tidal volume of 4 to 6 cc's per kilogram, and we attempt to keep the plateau pressure less than 30 with a PEEP greater than 5. So we never want the PEEP pressure to be below 5. And we always want the plateau pressure to be less than 30. And here's a summary of lung protective ventilation in patients with ARDS, as outlined by the ARDS clinical network, targeting a volume of 4 to 6 cc's per kilogram with a goal titrating that volume to achieve a plateau pressure less than 30. So in summary, ARDS is inflammatory injury to the pulmonary capillary walls, which leads to an exudate of protein-rich fluid, platelets, and erythrocytes into the alveoli. The clinical manifestations are hypoxemia, low compliance, or stiff lungs, and increased pulmonary vascular resistance. The criteria are acute onset less than 7 days after insult, bilateral lung infiltrates on imaging that are not cardiac, and a P to F ratio less than 300. The triggers are usually infectious, but also include things like aspiration, inhalation injury, pancreatitis, and fat embolus. And the only evidence-based intervention is lung protective ventilation with a tidal volume of 6 cc's to 4 cc's per kilogram of ideal body weight, a goal plateau pressure less than 30, and always maintaining a PEEP of 5 or greater using the PEEP scale, which we discussed earlier. All right, so let's talk a little bit about modes of mechanical ventilation. So what's the difference between volume control and pressure control? So in volume control, we set the volume and then we monitor the pressure. Whereas in pressure control, we set the pressure and then we monitor the volume. So at UCSD, in the medical ICU, we use volume control almost all the time. The advantage of volume control is it gives you very tight control over the volume of each breath. And recall that minute ventilation, the amount of air that you breathe in 1 minute, is a product of respiratory rate and tidal volume. So by controlling the tidal volume, you have very tight control over minute ventilation. The decision to use volume control versus pressure control is really based on institutional preference, and it's probably not worth getting into the nuances. So there's lots of fancy modes that you really don't need to know about. And additionally, different brands of ventilator have different names for the exact same modes, which makes it even more confusing. So we're just going to talk broadly about the concept of mechanical ventilator modes, and then we'll touch on 4 of the most common modes that you're likely to encounter in the ICU. So conceptually, all ventilator modes have 3 parameters. And what are those parameters? Yeah, so the first is the trigger, appropriately named, is what triggers inhalation. So that could be time. So for example, if the ventilator is set to 20 breaths per minute, then the trigger is time, and a breath will occur every 3 seconds. Or it could be patient triggered. So if the patient initiates a breath, the flow and the pressure will change and trigger the machine to initiate a breath. The next is the target, also appropriately named, is the target or goal of the ventilator. So if you're targeting volume, we set a volume of 500 milliliters, and the vent is programmed to reach that volume, but not exceed that volume for each breath. And the third is the cycle, and the cycle is what triggers exhalation. We're really just going to focus on the trigger and the target to keep things simple. Let's review a few of the common ventilator modes that you'll see in the ICU. So let's start with volume control. So in volume control, the trigger is time. So if you set 15 breaths per minute, then every 4 seconds the patient's going to get a completely assisted breath. And the target is volume. So let's just say that we set it to 500 cc's. So if you look on a volume time curve here, at 15 breaths per minute, every 4 seconds they're going to receive a breath of 500 cc's every single time. And if the patient tries to take a spontaneous breath in between breaths on their own, well, there's no option under the trigger for patient-triggered breath. It's just time. So they're just going to get breath every 4 seconds, breath after 4 seconds. If they try to initiate a breath in between, well, too bad. So every 4 seconds, they're going to get a breath. But you can imagine that this setting would be very uncomfortable. So we only use this in patients who are deeply sedated, for whom we need very tight control over their minute ventilation. The most common setting in the ICU is VCAC, which is volume control, assist control. And you'll notice the only thing that's different here is that there are now 2 types of triggers, time plus the patient. So in VCAC, if we set 15 breaths per minute, that patient's going to get a breath every 4 seconds. And you can see here, 4 seconds go by, the patient gets a mandatory volume of 500 cc's. 4 seconds go by, they get a mandatory volume of 500 cc's. But if they trigger a breath in between this, they're also going to get a mandatory volume of 500 cc's. So even if you set the rate at 15 breaths per minute, they might be taking 20 breaths per minute. And every time they take a breath, they're going to get that set target of 500 cc's. So the benefit of this is it's a little bit more comfortable for the patient as they're able to trigger breaths. The downside of VCAC is you have less control over minute ventilation, and these patients might be significantly overbreathing the vent, leading to a respiratory alkalosis. So it's a little bit more comfortable, but you get a little less control. The next is synchronized intermittent mandatory volume, which has mostly fallen out of favor, but I think it illustrates an interesting point. So in synchronized intermittent mandatory volume, again, we set the trigger as time and patient, but this time I've written here intermittent volume. So what does this mean? So if we set the rate at 15 breaths per minute, every 4 seconds the patient is going to get a set volume of 500 cc's. But if they try to trigger a breath on their own, rather than getting 500 cc's, there's no guaranteed volume. So if they try to initiate their own breath, this breath is completely unassisted. So the volume that they get on this self-triggered breath is just the volume that they're able to achieve on their own without the assistance of the vent. So again, looking here, 4 seconds go by, they get a mandated breath of 500 cc's. 4 seconds go by again, they get a mandated breath of 500 cc's. And then if they try to trigger their own breath, the volume of the breath is just whatever they're able to achieve on their own without assistance. So this is much more comfortable than VCAC, and it's better tolerated at lower levels of sedation, and it's good for weaning patients from the vent because, in part, they're just breathing spontaneously on their own. And then the final mode that we'll talk about is pressure support ventilation. So this is another setting that you'll see very commonly in the ICU when trying to wean patients from the vent. And in pressure support ventilation, we can see here the trigger is purely the patient. There is no time component. So if the patient doesn't trigger any breaths, mechanical ventilator won't breathe for them. So the patient has to trigger all of their own breaths. And the target is not volume now it's pressure. So there's no guarantee that they're going to reach any specific volume. We're just giving them a small amount of assistance with pressure. So if you look on this volume time curve, it might look something like this. The patient triggers a breath, and maybe they achieve 400 cc's, and then they trigger another breath, and maybe this time they get 300 cc's. They trigger another breath, and this time maybe they get 400 cc's, and so forth. But if they were to stop breathing, no breath would be triggered. So this is really the minimal amount of assistance that we can give the patient. It's the most comfortable for the patient because it closely mimics normal respiration. So this is a very common setting that you'll see in patients who are being weaned from the vent. So in summary, there are 3 main settings that you'll see. By far the most common one in patients requiring complete ventilatory support is VCAC. VCAC is used in the majority of the patients in the ICU. The patient can trigger their own breaths, but there's a backup trigger as well, which is time. So the patient will get a minimum number of breaths per minute, and then any breath that they trigger in between, they'll also receive the target volume of 500 cc's. And the other main setting you'll see is pressure support ventilation. And in this case, the patient triggers all of their own breaths, and there is no target volume. It's just a pressure goal. And this is a very useful setting for weaning patients from the vent. You can monitor the volume that they're able to achieve on their own and decide if they're ready for extubation. Okay, so let's move on to sedation and paralytics in the ICU. And we'll keep this section brief and high yield. So what are the goals of sedation? There's really three. A decreased level of consciousness, an amnestic effect, and third, you want the patient to be anesthetized. And all these are based around patient comfort. So in the ICU, patients are mechanically ventilated, which is extremely uncomfortable. Additionally, they have lots of lines, and the experience of being in the ICU is very anxiety provoking. So for them to be able to tolerate mechanical ventilation, you need to achieve these three things. And a fourth one that I won't put here, but that's important to think about is eventually you want to be able to extubate the patient. So what are the risks of excessive sedation? So excessive sedation is associated with prolonged intubation time, an increased risk of ventilator-associated pneumonia, and delirium. So while we do want patients to be sedated when they're in the ICU, excessive sedation is associated with risk. So what do we mean when we say over or under sedated? Well, how do we even quantify sedation? So we quantify sedation using something called the RASS score, the Richmond Agitation Sedation Scale. And you'll talk about this and hear a lot about this on your ICU rotation. So the scale is based on nursing evaluation of the patient. So 0 being someone who's awake and alert. -1 being someone who's drowsy but awakens to voice. -2 being brief awakening with eye contact to voice. -3 movement or eye opening to voice but no eye contact. 4 being no response to voice but movement or eye opening to physical stimulation. And -5 being no response to voice or physical stimulation. And this is evaluated by the ICU nurses periodically throughout their shift. So when you order sedation, you'll order it to be titrated to a RASS goal. So you might choose a RASS goal of -1 to -2 or a RASS goal of -3 to -4. So what goal do we want for patients to be adequately sedated while not being over-sedated? So for most patients in the ICU, our goal is 0 to -1, which means that these patients are essentially awake and alert. So what about in patients who are over-breathing the vent? This may mean that the patient is anxious, that they're agitated, and in that case, we try to improve vent dysynchrony by increasing the RASS goal. So in these patients, we may use -3 to -4. So that's moderate to deep sedation. So if the same patient continues to have vent dysynchrony, meaning that they're over-breathing the vent, they're breathing faster than the set rate, despite moderate to deep sedation, then we may have to consider using paralytic or neuromuscular blockade. And in these patients, we need to use a deeper level of sedation because you can imagine that it would be very traumatic to be paralyzed without adequate sedation on board. So in these patients, we use a goal of -4 to -5. So what are the two best agents for sedation in the ICU? The two main ones that we use are Precedex and propofol. And one of the big advantages of these two agents is that they don't have active metabolites that build up. So historically, prior to propofol and Precedex, we used things like benzodiazepines. And the active metabolites of benzodiazepines build up and make it very difficult to wean sedation and to extubate the patient. Benzodiazepine drips are also associated with high rates of ICU-associated delirium. Okay, so let's talk a little bit about the advantages and disadvantages of each. So what's the mechanism of action of Precedex? Precedex is an alpha-2 agonist, similar to things like clonidine. And what effects does it have? Which of the three goals of sedation does Precedex accomplish? So the three options are sedative effect, amnestic effect, and analgesic effect. Precedex really covers all three. So it has a good sedative effect, has a good amnestic effect, and it has a mild analgesic effect as well. So what are the advantages of Precedex? Well, the big advantage is that patients can be awakened from sedation without discontinuing the infusion. So Precedex creates kind of a dream state that patients can be woken up from. So although patients are sedated, you can wake patients up, perform a neurologic exam, and assess their ability to follow commands. And you can continue Precedex during the transition period from mechanical ventilation to spontaneous breathing. So what are the disadvantages of Precedex? So the two big disadvantages are, one, there's a decrease in both blood pressure and heart rate. The other disadvantage is that Precedex, while it does achieve a moderate amount of sedation, you can't achieve deep enough sedation for things like paralysis. So if you need deep sedation, you're better off using propofol. And as a brief note, while Precedex does have a mild analgesic effect, it may not be sufficient for patients with high levels of pain. For example, a post-operative patient. In these patients, in addition to Precedex, you will likely have to supplement with something like fentanyl. So in summary, Precedex is the preferred sedative agent in the ICU. Patients can be easily woken up and monitored on Precedex. It does have some analgesic effect, but you may need to supplement with an opiate. It can cause hypotension and bradycardia, and if you need very deep levels of sedation, you might be better off using propofol, such as in patients with paralytics. So let's talk a little bit about propofol. So what's the mechanism of action of propofol? So propofol is a GABA agonist. It acts on a different receptor than benzodiazepines, but it's in the same family of GABA agonists. And what are the effects of propofol? And again, the options are sedative effects, amnestic effects, and analgesic effects. So propofol is both sedative and amnestic, but it's important to note that it has no analgesic effects. So anytime using propofol, the patient should be on a fentanyl drip as well. And then what are the advantages of propofol? Well, one of the advantages is it has a very short duration, so it can be quickly turned off and the patient will be back at their baseline. Similar to Precedex, it also doesn't have any active metabolites that accumulate, so it's good for long-term sedation. One added benefit is that it also has an anti-epileptic effect. So in patients who recently had a seizure or there's concern for seizure, propofol can be used as an anti-epileptic. And then maybe the biggest advantage of propofol is that you can achieve very deep levels of sedation, more so than Precedex. So what are the disadvantages of propofol? Well, first off, like we mentioned, it has no analgesic property, so you have to supplement with an opiate such as fentanyl. It can cause significant hypotension, and then propofol has two feared complications. One is propofol infusion syndrome, which is a rare, poorly understood condition that's characterized by bradycardic heart failure, lactic acidosis, rhabdomyolysis, and acute renal failure. And it's associated with a mortality rate of 30%. So patients who are on a propofol infusion need to be monitored for propofol infusion syndrome by getting a CPK at least once a week. Then additionally, because propofol is prepared in a lipid emulsion, there's a risk for developing pancreatitis in patients who are on propofol. So at least once a week, you should check a lipase in a patient that's on propofol. So because of these complications and because there's no analgesic effect, Precedex is preferred. However, frequently you can't achieve adequate sedation with Precedex, and in those cases we prefer propofol. So briefly, you'll see fentanyl used frequently in the ICU, and the reason that we use fentanyl and not morphine or hydromorphone is that fentanyl does not accumulate in renal dysfunction. So fentanyl is the preferred opiate in the ICU, as many or most of the patients have impaired renal function. So we mentioned that both propofol and Precedex can cause hypotension. So you might be asking yourself, so what type of sedation can you use to avoid hypotension? So if you are in severe shock with low mean arterial pressures, you may see patients sedated with fentanyl alone. Fentanyl is hemodynamically neutral and may be preferred in cases of severe shock. All right, so let's talk a little bit about paralytics. So first off, do we use paralytics in all mechanically ventilated patients? No. And why not? Well, one of the goals when you intubate a patient is to optimize the likelihood of extubation. And when we use paralytics, there's no component of spontaneous breathing because the patient is paralyzed, so they can't breathe on their own. And for a prolonged period of intubation, patients can lose diaphragmatic strength. So one of the goals is to maintain the strength of the diaphragm by having the patient breathe spontaneously as much as possible. So the first reason we don't use paralytics is to maintain the strength of the diaphragm. The second is that the use of paralytics is associated with a higher risk of ventilator-associated pneumonia. So when should the decision be made to paralyze? Well, the first off is in severe vent dysynchrony, which we talked a little bit about earlier. So if a patient is significantly over-breathing the vent despite adequate sedation, then you may consider a paralytic. The other rule of thumb is in patients who have uncomfortable or unnatural breathing. So one example is permissive hypercapnia. So what is permissive hypercapnia? So permissive hypercapnia is a result of using lower tidal volumes. So remember from earlier we talked about ARDS, and in ARDS we use a tidal volume of 4 to 6 cc's per kilogram rather than the typical 8 cc's per kilogram. And by decreasing the tidal volume, we decrease minute ventilation. And in doing so, we increase CO2 retention, resulting in hypercapnia. And hypercapnia increases respiratory drive. So in these patients, despite using high levels of sedation, they'll usually be over-breathing the vent. So this is an example of a time where a paralytic can be useful to prevent ventilator dysynchrony. Other examples are prone positioning or the use of high levels of PEEP. In both of these, the patient is very uncomfortable, and the anxiety and agitation of these uncomfortable settings drive an increased respiratory rate, necessitating the use of paralytics. So generally, we avoid paralytics to maintain diaphragmatic strength and to decrease the risk of ventilator-associated pneumonia. And the times that we do paralyze are in patients with severe vent dysynchrony despite adequate sedation, and in those with uncomfortable or unnatural breathing patterns, so those with permissive hypercapnia, prone positioning, or use of high levels of PEEP. Okay, so we've talked about endotracheal tubes, tracheostomy tubes, ventilator settings, sedation, and paralytics. Let's put it all together and talk about rounding on your ventilated patient. So rounding on your ventilated patient can really be broken down into three things. Is it working? Is it safe? And when can it be discontinued? And this method is borrowed from Dr. Hepikoski and really can simplify rounding on your patient. So let's go through and answer each question. So is it working? So there's really three components of is it working. First is the patient oxygenating appropriately? And so to check this, you can look at the ABG that was drawn overnight, and you want to make sure that their PaO2 is greater than 60. And then when you're rounding on the patient, look at their pulse oximeter and make sure that their O2 saturation is greater than 90%, but you want it to be less than 100%. Because if the pulse oximeter reads 100%, you don't know if their PaO2 is 80, which would be within normal range, or if it's 300. And excessive oxygenation is associated with vasoconstriction. The second thing that you want to check is their CO2. Are they clearing CO2 appropriately? And again, this can be checked on the ABG, and you want to make sure that their PCO2 is between 35 and 45. If they have an end-tidal CO2 monitor attached to the ventilator, you can also monitor CO2 there as well. And then the third thing you want to check is the patient overbreathing the vent? So to do this, you're going to look at the set rate, and then you're going to look at the actual rate that they're breathing. Then you can also look at the volume and the flow curves, and you can see if they're starting to trigger a breath before they get to their next set breath. So for oxygen, check the ABG overnight. When you're rounding on the patient, check the pulse ox, and then check the ABG to make sure that their CO2 and pH are within normal limits. And once you're in the patient room, check that the set rate and the actual rate are the same. So the next question you want to ask yourself is it safe? So the main thing that you're checking here are peak pressures. You want to make sure that the peak pressure is below 40. And you want to make sure that the plateau pressure that we talked about earlier is below 30. The plateau pressure is checked with an inspiratory hold like we talked about earlier. And at some point on your rotation, you can ask either the attending fellow or the respiratory therapist to show you how to get a plateau pressure. And the other major component of is it safe is to make sure that the ET tube, the endotracheal tube, is correctly placed. So you get a daily chest x-ray. We talked earlier about how to confirm ET tube placement on a chest x-ray. So for is it safe, check the peak pressures as you're rounding on the patient, make sure they're below 40. If you know how, you can check the plateau pressure, make sure it's below 30, and then check an x-ray daily to make sure that the ET tube hasn't migrated. And the last question you want to answer as you're rounding on the patient is to ask, can it be discontinued? Are we getting close to being able to extubate this patient? So what FiO2 do you think needs to be met before you consider extubating a patient? Well, as you're working your way down the PEEP ladder, like we talked about earlier, as you're getting close to a FiO2 of 50%, then you can start considering the possibility of extubation. So an FiO2 of less than 50% should be met before you consider extubating the patient. And then what PEEP should be met? Yeah, so a PEEP less than 8. So as you're working your way down the ladder, you should be at a point where the FiO2 is less than 50% and the PEEP is less than 8. And then what PaO2 to FiO2 ratio should be met? So greater than 200. And you can type the PaO2 FiO2 ratio into MD-Calc. So you get the PaO2 from an ABG and the FiO2 is the setting on the vent. So in review, as you're rounding on your patient, there's three things to ask yourself to incorporate into your presentation. So is it working? So for is it working, look at the ABG from overnight and you make sure that they're oxygenating appropriately and that their CO2 is within normal limits. And then as you're rounding on the patient, check their pulse oximeter, make sure that their oxygen saturation is above 90 but below 100. And then look at the respiratory rate. Look at their set respiratory rate versus their measured respiratory rate. Make sure they're not over-breathing the vent. And then to ask yourself, is it safe? It's two things you want to check. Look at the ventilator and look at their peak pressures. You want those peak pressures to be below 40. And if you know how, you can check a plateau pressure, and you want that plateau pressure to be less than 30. Now, the second thing you're going to look at is the chest x-ray. You're going to make sure that the ET tube is in the appropriate position on the chest x-ray. And then the third thing you want to ask yourself is, can it be discontinued? And to meet this criteria, the FiO2 should be less than 50%, the PEEP should be less than 8, and the P to F ratio should be greater than 200. And you can calculate this by checking the PaO2 on the ABG, and the FiO2 can be found on the vent settings. Okay, so let's talk about extubation readiness. So, as you were rounding on your patient, you asked yourself the question, can it be discontinued? And you noticed that the FiO2 was less than 50%, the PEEP was less than 8, and the P to F ratio was greater than 200. So, what's the next step? Do you just pull the ET tube at that point and hope for the best? No. So, you want to make sure that the patient can breathe spontaneously before you pull the ET tube to avoid reintubation. And this is where something called a spontaneous breathing trial is very useful. So what is a spontaneous breathing trial? So in a spontaneous breathing trial, we place the patient on very minimal vent settings, just enough to overcome the resistance from the airway circuit. So one option is to put them on continuous positive airway pressure, or CPAP, at 5 to 8, or we can do low-level pressure support ventilation, which we talked about earlier. Regardless, the point is you put them on very minimal vent settings for at least 30 minutes up to 120 minutes, and you watch to see how they do with these minimal vent settings to try to simulate what it'll be like when you extubate the patient. And what things do we monitor during this spontaneous breathing trial? So you monitor two things, the respiratory rate and the tidal volume. And you can imagine that if the patient is in significant respiratory distress, their respiratory rate will be high and their tidal volume will be low. They'll be taking rapid, shallow breaths. So how do we interpret this? Well, we use something called the Rapid Shallow Breathing Index, or the RSBI. So we take the respiratory rate during the spontaneous breathing trial divided by the tidal volume. And if that ratio is less than 105, then there's a high chance of success. And ideally, we want it to be even lower, around 50 or 60. And intuitively, this rapid shallow breathing index score makes sense because we want the respiratory rate to be low or normal, because this indicates the patient is not in respiratory distress, and that will drive the RSBI score down. And we want the tidal volume to be large because this indicates that the patient is taking full, deep breaths, which will also drive the rapid shallow breathing index down. So the way you calculate it is the respiratory rate as breaths per minute and the tidal volume in liters. So let's say the respiratory rate is 15 and their tidal volume is 500. That'd be 15 divided by 0.5. So at this point, they're oxygenating well. Their FiO2 is less than 50, P less than 8, P to F greater than 200. Their RSBI score is less than 105. The third thing you want to check is their mental status. And to do this, you turn off sedation, and then you want to make sure they can follow commands. You ask the patient to squeeze your hand, ask them to move their feet, and then ask them, do you want us to remove the tube? And in patients who have normal mental status, they will be very excited to have the tube out, and they'll indicate that they want the tube removed. So assuming that all three of these criteria are met, then the last thing to do is check for a cuff leak. So this is especially important in patients who've been intubated for a long period of time, but it should be checked in all patients prior to extubation. And to perform a cuff leak, use the inflation line that we talked about earlier to deflate the endotracheal cuff. And then with positive pressure ventilation, we can calculate the difference between the expired tidal volume with the cuff inflated and with the cuff deflated to evaluate for a leak. And the reason we do this is that in a patient with significant laryngeal swelling, the surrounding tissue will push in on the tube and you won't have an air leak around the tube. And if there's no leak around the tube, then they're at high risk of the airway closing off after extubation because of all the surrounding swelling. And if no cuff leak is detected, those patients are treated with steroids prior to extubation. And then once the patient is extubated, evidence supports placing the patient onto high-flow nasal cannula immediately after extubation, and this minimizes the chances of needing to re-intubate the patient. If the patient has a history of COPD, obesity, hypoventilation, or cardiopulmonary disease, then rather than high-flow, use BiPAP, followed by high-flow. So in summary, when you think the patient's ready to extubate based on their oxygenation, then you'll order an SBT. Another term for SBT is sprint trial. Calculate a RSBI score. If it's less than 100, then you want to ensure that their mental status is appropriate for extubation and that they're able to protect the airway. So you minimize sedation, ask them to follow commands. And the final step before extubation is evaluating for a cuff leak. If no cuff leak is detected, then you give them steroids prior to extubation. Okay, so let's talk about shock and vasoactive medications, colloquially known as pressors. So before we talk about pressors, let's talk about how we measure and evaluate blood pressure in the ICU. What blood pressure parameter do we use in the ICU? Yeah, so we use the mean arterial pressure, or the MAP. And why do we use mean arterial pressure? So organ and tissue perfusion doesn't depend on the systolic or the diastolic blood pressure alone. It depends on the mean arterial blood pressure, which is the average blood pressure through one cardiac cycle from systole to diastole. So we use mean arterial pressure to determine if there's sufficient end organ and tissue perfusion, because the systolic and the diastolic pressure alone doesn't tell us whether or not tissue is being sufficiently perfused. And what's the minimum mean arterial pressure required to perfuse vital organs? MAP of 60. So a MAP of 60 or greater is required to perfuse end organs. So we always want the MAP to be above 60, and if it's below 60, that's when you'll start seeing a type 1 lactic acidosis. So how do you estimate or calculate the mean arterial pressure? So if a patient has an arterial line in place, we can directly monitor the mean arterial pressure. And this is why patients on vasoactive medications usually have an arterial line in place, so that you have real-time monitoring of the arterial pressure. But if the only information that you have is the systolic and diastolic blood pressure from a blood pressure cuff, you can still estimate the mean arterial pressure with the following formula. The diastolic pressure, which is most of the time that we spend in the cardiac cycle, and then you add 1/3 of the pulse pressure, the difference between the systolic pressure here at the peak and the diastolic pressure here at the nadir. In reality, you never have to calculate the mean arterial pressure because it's calculated for you and can be found under the vitals tab, or if the patient has an arterial line, it can be found on the blood pressure tracing at the bedside. Another way to conceptualize mean arterial pressure is to think about it in terms of cardiac output times systemic vascular resistance, where the cardiac output really determines the systolic pressure, whereas the systemic vascular resistance, or how tightly the blood vessels are clamped down, determines the diastolic pressure. So in the ICU, what mean arterial pressure do we titrate pressors to? So generally, we titrate to a mean arterial pressure of greater than 60, since a minimum of 60 is what's required to perfuse end organs. And there are some exceptions. I've listed 2 of them here. One is in sepsis, our goal is greater than 65, and in post-cardiac arrest, goal is greater than 65. But generally speaking, a MAP of 60 is the minimum pressure needed for tissue and end organ perfusion. Very briefly touch on pulse pressure. So how do we calculate pulse pressure? So pulse pressure is a simple calculation. It's just the systolic pressure minus the diastolic pressure. So the difference between the peak of systole and the nadir of diastole. So what is the utility of pulse pressure? Well, pulse pressure can be helpful in differentiating types of shock. So again, the systolic pressure is really determined by cardiac output, how well the heart can squeeze. And the diastolic pressure is determined largely by vascular tone, or how well the blood vessels are able to constrict. So if there's an issue with cardiac output, then the systolic pressure will be low, and the diastolic pressure will be higher to maintain mean arterial pressure. So in patients with a cardiac etiology of shock, the systolic pressure goes down and the diastolic pressure goes up, and so the difference between the two of them decreases, and so we get a narrow pulse pressure. And a narrow pulse pressure is defined as a pulse pressure less than 25% of the systolic pressure. For example, if you had a systolic pressure of 100 and a diastolic pressure of 80, the pulse pressure would be 20, which would be 20% of the systolic pressure of 100. So this would be considered a narrow pulse pressure and should raise concern for cardiac issues such as cardiogenic shock, tamponade, or severe aortic stenosis. Okay, so what is shock? So shock is caused by circulatory failure, which results in inadequate perfusion pressure to meet the oxygen requirements of tissue and organs. So when should we suspect shock, or what is the clinical constellation of patients who are in shock? Well, like we just talked about, the best marker for adequate perfusion is the mean arterial pressure. A mean arterial pressure of greater than 60 is required for end organ perfusion, and those with a mean arterial pressure of less than 60 can be considered to be in shock. And while MAP is a very useful tool, it's only part of the total clinical picture. So one of the most useful labs is a lactate, because when there's insufficient perfusion, the body shunts pyruvate towards the production of lactate rather than oxidative phosphorylation. So lactate is a sensitive marker of whether or not tissue is receiving adequate perfusion. So a lactate greater than 2. Another sensitive marker is urine output. So in normally perfused kidney, we can expect a urine output of approximately 0.5 cc's per kilogram per hour. So in patients who are making less than 0.5 cc's per kilogram per hour, you should suspect that the kidney is not adequately perfused, and this may reflect the state of shock. So mean arterial pressure, a lactate, and a low urine output are all sensitive markers of both an early and late stages of shock. However, other end organ manifestations, such as transaminitis, an elevated creatinine, or altered mental status, tend to present in later stages of shock and may not be very sensitive to early stages of shock. All right, so before we talk about specific pressors for different types of shock, a quick note on differentiating types of shock. So there's lots of great resources for learning how to differentiate shock. Keep this brief and high level. A lot of our clinical training as it pertains to differentiating types of shock is focused on testing our understanding of hemodynamics on a right heart catheter. Now, is the cardiac output up or down? Is the systemic vascular resistance increased or decreased? Is the central venous O2 up or down, etc.? But most of the time, the etiology of shock can be determined with a clinical context, vitals, labs, and a bedside echo. So this slide isn't meant to be memorized, but just to paint a clinical picture and give you a framework to think about how to work up a patient in shock. So you always want to have a good history, a good set of vitals and labs. So for example, for cardiogenic shock, likely has a history of heart failure, myocardial infarction, or a tachyarrhythmia. On the vitals, they're going to have a low pulse pressure, and on their labs, they're very likely to have an elevated BNP and an elevated troponin. And in obstructive pathologies such as massive pulmonary embolism, this might be a patient who has a history of cancer, a hypercoagulable state, they've been off anticoagulation, they have a history of DVT or lower extremity swelling. On the vitals, you'll see tachycardia. And in the case of tension pneumothorax, looking for clinical signs like sudden onset shortness of breath, chest pain. On a chest x-ray, you can identify pneumothorax. So for hypovolemic, again, clinical context is key. Is this a post-operative patient? Do they have recent trauma? Do they have frank bleeding? Are they anemic? And for distributive, which includes varying etiologies, for sepsis, do they have an infectious source? Do they have a fever? Do they have a leukocytosis? For liver failure, do they have a history of cirrhosis? On physical exam, do they have findings of cirrhosis? For anaphylactic shock, do they have wheezing? Do they have rash? Do they have stridor? Were they recently exposed to a medication that might cause an anaphylactic reaction, such as a blood transfusion or iron? And then with a bedside echo, in a patient in cardiogenic shock, they're going to have poor cardiac contractility. And in a patient with obstructive shock, if it's caused by cardiac tamponade, you're going to see a large pericardial effusion on bedside echo. If it's caused by a massive pulmonary embolism, you're going to see right heart strain. And if it's caused by a pneumothorax, and you know how to do a lung exam, then you're going to see absent lung sliding. And for hypovolemic patients, their IVC is going to be small. It's going to be less than 2.1 centimeters and collapsible. And in distributive shock, these patients will have a hyperdynamic heart, though in late distributive shock, patients can also develop poor contractility. But the point of this slide is really just to say that between clinical context, vitals, labs, and a bedside echo, you can usually differentiate the type of shock. Where it becomes more difficult to evaluate the type of shock is when there's multiple concurrent etiologies. So for example, patients who have cardiogenic shock as well as sepsis, or cardiogenic shock as well as liver failure. And if there's still question as to what type of shock it is, a right heart cath can be useful in differentiating types of shock. So when you go to evaluate a patient on the floor or in the emergency department and there's concern for shock, make sure to always look at the clinical context, vitals, labs, and perform a bedside echo, look at cardiac contractility, and try to visualize the IVC. This will greatly narrow your differential. And here's a table of the IVC collapsibility index that will help you to interpret your findings on your bedside examination of the IVC. Okay, so now let's talk some about vasoactive medications or pressors. Normally you see pressors given through a central line. So what's the risk of giving pressors peripherally? Yeah, so the risk is extravasation of the pressor. So if the peripheral line gets dislodged from the vein, then the pressor can extravasate or spill out into the surrounding tissue. And when it does so, it causes local vasoconstriction, which can lead to tissue necrosis, which you can see here in this picture. So for that reason, we give pressors through a central line to avoid extravasation and tissue necrosis. But is it ever acceptable to give pressors peripherally? It is acceptable to give vasopressors peripherally for a short amount of time, generally for 6 hours or less, though the guidelines vary by institution. And these patients have to be closely observed and monitored for extravasation. But only pressors that have a reversal agent can be given peripherally. And this is because if extravasation does occur, then you have to have a reversal agent that you can give to prevent irreversible tissue necrosis. So what pressors do have a reversal agent, and what is that agent? So pressors whose mechanism of action is alpha agonism, so things like epinephrine or norepinephrine, can be given peripherally for these short periods of time. And that's because we have an alpha antagonist that can be given in the case of extravasation, and that agent is called phentolamine, which is a non-selective alpha antagonist. So norepinephrine and epinephrine can be given peripherally for a short period of time, and if there's concern for extravasation, phentolamine can be given subcutaneously into the affected area. Other pressors without a reversal agent cannot be given peripherally. An example of this would be vasopressin, which acts on the V1 receptors, does not have a reversal agent, so cannot be given peripherally. So this is why we use central lines to give pressors. Okay, so how do you choose which pressor to use? So the main thing that you want to consider is, do you need inotropy, vasoconstriction, or both? And as you recall, with pressors that act on alpha receptors cause vasoconstriction, those that act on beta receptors cause inotropy. So another way to think about this is in terms of vasopressors here on the left and inotropes on the right, and those with mixed effect here in the middle. And again, whether a vasoactive medication is considered to be a vasopressor or an inotrope or a combination depends on what receptors that vasoactive medication acts on, alpha, beta, or both. And then if you're thinking about vasopressors versus inotropes, you can also think about other vasoactive medications that don't necessarily act on alpha or beta, like vasopressin, which acts on the V1, V2 receptors and is a pure vasopressor, or milrinone, which is a phosphodiesterase 3 inhibitor and is a pure inotrope. So the first thing to ask yourself is, do you need inotropy, vasoconstriction, or both? And that's really the biggest question you have to ask yourself when choosing a pressor. The second thing to ask yourself is about arrhythmogenic effect. Generally, the more beta active, the more arrhythmogenic, meaning that it can precipitate tachyarrhythmias. So medications like epinephrine, dopamine, and dobutamine tend to be very arrhythmogenic. So in order from most to least arrhythmogenic, dopamine tends to be very arrhythmogenic, epinephrine and dobutamine moderately arrhythmogenic, and norepinephrine somewhat arrhythmogenic. But a medication like phenylephrine has no arrhythmogenic property. Okay, so with those things in mind, let's go through pressor selection in septic shock and cardiogenic shock, and then briefly go through and discuss each vasoactive medication. So probably the most common type of shock you'll see in the medical ICU is septic shock. So what's the management of septic shock? Well, of course, antibiotics and source control, and then fluid resuscitation. So you give 30 milliliters per kilogram for patients with sepsis who are hypotensive or have a lactate greater than 4. And the Surviving Sepsis campaign recommends starting vasopressors early within the first hour after administration of fluids, if fluid administration is not sufficient to achieve hemodynamic resuscitation goals. So if pressors do not improve with fluid, what's your first line pressor for septic shock? So based on the Surviving Sepsis campaign expert consensus, norepinephrine, brand name Levophed, is the first line pressor. And again, we titrate to a MAP goal greater than 65 in patients with septic shock. And the dosage range of norepinephrine can be titrated anywhere between 2 to 80 micrograms per minute. And what would the second line be? So the second line is vasopressin. So once reach a dose of Levophed of 15 or greater, then add on vasopressin as a second line agent. Vasopressin is not a titratable pressor. So vasopressin set at 0.4 units per minute at a fixed rate. All right, so in summary for septic shock, first line pressor is norepinephrine, brand name Levophed. When you order it, you'll titrate it to a goal mean arterial pressure of 65 or greater. And as it's being up titrated, once you reach a dose of 15 micrograms per minute, then start vasopressin. In terms of a third line agent, there is not a agreed upon third line agent and will usually depend on clinical context. Potential third-line agents include epinephrine, phenylephrine, or dopamine. If you believe there's a cardiogenic component to the shock, dopamine may be favored. If there's concern for arrhythmias such as atrial fibrillation with RVR, it might be beneficial to choose something without beta agonism and arrhythmogenic properties like phenylephrine. Okay, so let's talk about cardiogenic shock. So what's the first-line vasoactive medication in patients with cardiogenic shock? So to answer that question, let's briefly talk about the pathophysiology of cardiogenic shock. So in cardiogenic shock, the issue is with low cardiac output. So to augment cardiac output, we want to increase the stroke volume, or the amount of blood the heart pumps with each contraction. Things that positively affect stroke volume are contractility, which increases with inotropy. Things that negatively affect stroke volume are things like afterload, which increase with vasoconstriction. So in a patient with cardiogenic shock, the worst thing you could give is something like phenylephrine. It increases afterload without affecting contractility, which would effectively decrease cardiac output and result in worsening cardiogenic shock. So you may think then that the best option would be a medication with pure inotropy, like dobutamine. And that's true if the blood pressure is maintained. So in cardiogenic shock, if the mean arterial pressure is greater than 60, but there are still clinical signs of shock, including low urine output less than 30, cool extremities, or a cardiac index of less than 2.2 on a right heart catheter, then the first-line vasoactive medications are pure inotropes, so either dobutamine or milrinone are first line in cardiogenic shock. However, if the blood pressure is low, as defined by a mean arterial pressure less than 60, then in addition to inotropy, some alpha agonism or vasopressor activity is required to increase the blood pressure to maintain organ perfusion. And it turns out the vasoactive medication with the best outcomes in cardiogenic shock with low blood pressure is norepinephrine. So norepinephrine is the first line agent in cardiogenic shock with low blood pressure. Norepinephrine gives significant inotropy without significant increase in afterload, and compared to epinephrine is much less likely to cause tachyarrhythmias. So the first line in cardiogenic shock with low blood pressure is norepinephrine. Then as a second line, both dobutamine and milrinone can be used. And a third line agent is dopamine. If patients continue to be in shock, as evidenced by decreased urine output, increased lactate, MAP below 60, you may have to consider mechanical support with intra-aortic balloon pumps, Impellas, or ECMO. But in terms of pressor selection, in those with cardiogenic shock and low blood pressure, the first-line vasoactive medication is norepinephrine, followed by dobutamine or milrinone, and a third-line option is dopamine. Okay, so let's go through each of these individual pressors and just talk about some clinical uses. We've already talked about norepinephrine. Norepinephrine is really a workhorse of the medical ICU. It's the first line in septic shock, and it's the first line in cardiogenic shock with low blood pressure. It's also the first line in hypovolemic shock. So when in doubt, start norepinephrine. All right, so what about epinephrine? So the main uses for epinephrine are in anaphylactic shock, in cardiac arrest, so you'll see this used in codes, as push dose, or as salvage therapy, meaning third line therapy. For example, in septic shock, epinephrine sometimes used as the third line after vasopressin. Phenylephrine is a pure alpha agonist, and the main indication is in anesthesia-induced hypotension. For example, when patients get started on propofol or Precedex, you may see a drop in blood pressure, and this is due to vasodilation. So using a pure alpha agonist that acts as a vasopressor can counteract that vasodilation. Similarly, in neurologic hypertension, you may see vasodilation. And then in patients for whom tachyarrhythmias preclude the use of norepinephrine or epinephrine, for example, a patient who goes into atrial fibrillation with RVR or other supraventricular tachycardias, phenylephrine can be used as a substitute as it has no beta agonism and is not an arrhythmogenic vasoactive medication. Dobutamine. So dobutamine is the first-line vasoactive medication in patients with cardiogenic shock and a maintained blood pressure. And second line in cardiogenic shock with low blood pressure after norepinephrine, and is a pure beta agonist. In patients with septic shock who are already on norepinephrine, if there's any concern for cardiac dysfunction, dobutamine can be added on. Milrinone, again, is first line, just like dobutamine in patients with cardiogenic shock and a maintained blood pressure. The advantage of milrinone is that it decreases pulmonary vascular resistance. It can be used in patients with right-sided heart failure or in those with severe pulmonary hypertension. Milrinone is renally excreted, so it's contraindicated in those with severe renal impairment. And this is referred to as the Do-Re-Mi trial, in which patients with cardiogenic shock were randomized in a 1-to-1 double-blinded fashion to receive either milrinone or dobutamine. And the results of the trial showed that patients with cardiogenic shock, there was no significant difference between using milrinone versus dobutamine with respect to the primary outcomes of in-hospital death from any cause, cardiac arrest, or need for cardiac mechanical circulatory support. Okay, so let's talk a little bit about steroid use in the ICU. So the rationale behind using steroids in patients with sepsis and septic shock is based on data which suggested that critical illness induces a state of absolute or relative adrenal insufficiency, and that may contribute to the shock. However, multiple subsequent studies have disproved this theory, and the use of steroids is highly controversial. But despite the controversy, we continue to use steroids in patients with septic shock refractory depressors. And the dosing we use is either hydrocortisone IV, 50 milligrams Q6 or 100 milligrams Q8 for 5 to 7 days. And stress dose steroids are only used in septic shock, not for other forms of shock. And there's no clear guidelines on when to start stress dose steroids. So generally, once patients with septic shock are on one or more pressors, stress dose steroids are started. Other time the stress dose steroids are used are in patients with known adrenal insufficiency. So once a patient with shock is maxed on 3 to 4 pressors, there's a couple of last-ditch agents for refractory shock. The first one is angiotensin II, and specifically angiotensin II is effective in increasing blood pressure in patients with vasodilatory shock, such as sepsis. And here's a reference to a RCT published in the New England Journal of Medicine in which they assigned patients with refractory shock to angiotensin II or placebo, and they found that angiotensin II effectively increased blood pressure in patients with vasodilatory shock that did not respond to high doses of conventional vasopressors. So angiotensin II may be added on as salvage therapy in patients with a refractory vasodilatory shock. Another salvage therapy you might see is methylene blue, which acts as a nitric oxide scavenger to reduce systemic vasodilation. Methylene blue is also used as a salvage therapy in vasodilatory forms of shock, similar to angiotensin II. And because of its role as a nitric oxide scavenger, it may be used in patients with advanced cirrhosis, as the pathophysiology of shock and cirrhosis involves high levels of circulating nitric oxide. And this is a picture of methylene blue on the right here with this dark blue color. But regardless, both of these agents are really last-ditch agents in patients who are maxed out on 3 to 4 pressors. Okay, in this last very brief section, we're just going to cover a couple general concepts in the ICU, including ICU admission criteria, CRRT, and a rounding mnemonic known as fast hugs, BID, and then a slide on the differential for fever in the ICU. So what are the indications for admission to the ICU? So the first big one are nursing requirements. So any patient that requires Q1 hour nursing requirements or more frequent has to be admitted to the ICU. And that even includes something like Q1 hour eye drops. This has to do with the nursing ratios because in the ICU, the ratio is less, usually one nurse per 2 patients and sometimes even 1-to-1. The next big category are ventilation requirements. Anyone on a mechanical ventilator has to be in the ICU, and anyone that's on either CPAP or BiPAP. The exception for CPAP and BiPAP is if you're on your home settings only at night. So for example, a patient with obstructive sleep apnea who uses a CPAP at night does not need to be in the ICU if they're on their home settings only at night. Next big category are titratable drips. So any patient that's on a titratable drip, whether that's a pressor or an antihypertensive, has to be in the ICU. And the reason for this is that you order titratable drips with a set of parameters. For example, a systolic pressure greater than 100 and less than 160. And this is very time intensive for the nurses as the drip rate has to be constantly adjusted to meet a narrow set of parameters. So in summary, indications for the ICU are nursing requirements of Q1 hours or less, mechanical ventilation, BiPAP or CPAP, with the exception of those on their home settings only at night, titratable drips, including pressors or antihypertensives, and patients on CRRT or continuous renal replacement therapy, which we'll talk about next. So what is continuous renal replacement therapy, or CRRT? Well, the very brief version of CRRT is that it's a slower, continuous form of dialysis. So hemodialysis is usually run over 4 hours, whereas CRRT is run continuously 24 hours a day. And since hemodialysis is limited to a short period of time, there are large fluid shifts during dialysis. So for example, if the goal is to remove 2 liters of fluid, in dialysis, you would have to remove 500 milliliters per hour over the course of 4 hours. Whereas in CRRT, which is run over 24 hours, if your goal is to remove 2 liters of fluid, you can remove that fluid at around 80 milliliters per hour over the course of 24 hours. So this results in smaller fluid shifts. And in patients with hypotension or who are requiring vasopressors, those patients will not be able to tolerate the rapid fluid shift associated with hemodialysis. So the indication for CRRT is in patients who are on vasopressors or who are too hypotensive to tolerate hemodialysis. So what's the mechanism of CRRT? Well, the mechanism is actually complex, but the summary is that in patients on CRRT, blood flows continuously from the patient through the CRRT machine and passes through a filter. And in the filter, a gradient is created using dialysate solution. And via this gradient, electrolytes and fluid are removed. And by deciding which dialysate to use and what fluids to give back before the filter and after the filter, as well as which Prismasol solution to use, which is the solution that's given back to the patient, you can control the fluid balance per hour as well as electrolytes. So what specific things are actually controlled on CRRT? So when you decide on the settings for the CRRT, you can decide fluid balance per hour. As an example, you could set it at positive 25 milliliters per hour for a net positive of 600 milliliters in 24 hours. Or you could set it to be negative 100 milliliters per hour for a net negative 2.4 liters over the course of 24 hours. Again, by controlling the Prismasol or the replacement fluid and the pre and post filter fluids that you give back to the patient and the dialysate, which creates the gradient in the filter, you can control potassium, magnesium, as well as bicarb. And then from a second lumen on the central line, you can control how much calcium is given back to the patient. So you can control the potassium, magnesium, calcium, and the bicarb with CRRT. Notably, CRRT does not control the phosphate, and phosphate must be given separately, either IV or enterically. Okay, next let's briefly talk about a mnemonic known as Fast Hugs BID, which is a mnemonic used for recalling key issues to review when looking after critically ill patients in the ICU. And usually at the end of presenting a patient, they'll go through each of the letters in this mnemonic, the rest of the team and an ICU nurse at bedside. So the first is feeding. It's easy to forget in patients in the ICU with so many other issues going on, whether or not they're receiving tube feeds. So when you're rounding on the patient, you can ask the nurse if they're receiving tube feeds and check the orders to make sure that they are actually receiving tube feeds, either bolus or continuous. The next is A for analgesics, and you want to just briefly mention what analgesics the patient is on. For example, if the patient is on propofol alone, you want to make sure that they also have anesthetic effects with fentanyl. The third is sedation. And when talking about sedation, you want to mention what type of sedation they're on, whether it's propofol, Precedex, fentanyl alone, and then what RAS goal the sedation is being titrated to. And this is important to prevent over-sedation, which can lead to increased rates of ventilator-associated pneumonia, or under-sedation, which can cause agitation and overbreathing the vent. The next is thromboprophylaxis. Briefly mention if the patient's on heparin, Lovenox, an external compression device, etc., just like you would with a floor patient. And then we have H for head of the bed. And if you recall, it's important that the head of the bed be elevated in mechanically ventilated patients, as this decreases the risk of ventilator-associated pneumonia. In other patient populations, such as those with increased intracranial pressure, you also want to make sure the head of the bed is elevated. The next is U for ulcer prophylaxis. So patients who are at very high risk of formation of stress ulcers are those on mechanical ventilation for greater than 48 hours, or those with a coagulopathy. Other high-risk factors include patients with a history of gastric ulcer or GI bleeding in the last 12 months, or those with traumatic brain injury, spinal cord, or burns. So most patients in the ICU should be on ulcer prophylaxis. And recent meta-analysis comparing H2 blockers versus PPIs found less GI bleeding among those who receive PPIs. So review that the patient is receiving a PPI. The next is glycemic control, and for this you can just briefly mention whether or not the patient has had any uncontrolled blood glucose levels or if they're on an insulin drip. And then for skin breakdown, the nurses will evaluate the patients daily per skin breakdown, and you can ask the nurses if they've noted sacral skin breakdown or ulceration. Next is bowel regimen. This is another easy one to forget about in patients who are receiving opiates. We want to make sure that the patient is having bowel movements, so review what bowel regimen the patient is on. The next is indwelling lines or access. And we want to remove any unnecessary lines. So you can briefly mention whether or not that the patient has a central line or an arterial line. If they don't need it anymore, consider removing it. And finally, D is for de-escalation of antibiotics. Briefly mention what antibiotics the patient is currently on. And if they're on broad antibiotics, consider de-escalation to more targeted therapy. The last topic we'll very briefly touch on is fever in the ICU. And the differential for fever in the ICU is somewhat different than patients on the floor. So fever in the ICU can be broken up into non-infectious and infectious etiologies. We're not going to go through all these, but a couple important ones to consider in a patient with undifferentiated fever in the ICU for whom no infectious source has been found are drug fever, and specifically, like we talked about earlier, Precedex can cause fever, and acalculous cholecystitis. So in patients with acute illness, they're at higher risk of developing acalculous cholecystitis, which can be evaluated with a bedside ultrasound. One infectious source of fever in the ICU are sinus infections, especially if the patient has an NG tube. And NG tubes can block off the paranasal sinus ducts and lead to sinus infections. So if you've ruled out other causes of fever in the ICU, you may consider getting a CT maxillofacial to evaluate for sinus infection. And lastly, this slide is a list of resources that cover topics you'll encounter in the ICU.